This afternoon is really aimed at our fellows and trainees. Fabulous. All right. So the goal of this afternoon will be, again, it's designed specifically with our trainees in mind, and we will be sharing some case presentations as they pertain to pediatric endocrinology. I'll have Dr. Krishnan share the first one here, and I will let you have that. Following the case presentations, we're going to have kind of a panel discussion of different career paths, and we'll try to kind of moderate that best we can because we know we have a lot in our virtual audience as well. Again, we welcome everybody and thank you for coming. We are thrilled that you are here with us. All right, Dr. Krishnan, I will let you kind of take this away and
thank you, Dr. Tregestead. As Dr. Tregestead introduced, I'm Dr. Krishnan. I'm one of the faculty at University of Oklahoma. And I'm going to start off with an interesting case. The way I've designed this case presentation is it's supposed to be interactive. So please feel free to put in your chats. And actually, let's see. What did I do? I decreased the chat box and I thought I should have, oh, sorry, Ginny, I minimized my chat box and I should actually have it up. Pin your questions or even unmute yourself and ask questions as needed. So this is an interesting kiddo, 15-month-old female referred to us for growth attenuation. Parents report that the child is dropping both the weight and height percentiles at PCP's visits. They don't have any other developmental concerns. Child is meeting all the developmental milestones. Past medical history, surgical history is unremarkable. Child was born with a normal birth weight, normal vaginal delivery, no problems during prenatally or postnatally. Now, mother is provider. So she is a family practitioner and she knows about growth and stuff like that. And both parents are pretty tall. Mother is 71 inches, which is 5'11", and dad is 6'1". Family history is unremarkable, apart from maybe maternal grandmother having type 2 diabetes. So this is the growth chart that we got from the primary care physician's office. And as you can see, the weight is slowly creeping down. And the length is also creeping down. Now, technically, both of them are not below the growth chart, but just because parents were pretty tall and mom being in the medical field, she was concerned. And so they were referred to see us. On the day they came to establish care with us, the child's length was at the 22nd percentile, weight was at the 1 percentile, and head circumference 35th percentile. Otherwise, the exam was pretty unremarkable. There was nothing noted. So keeping this in mind, who would have done further workup on this child? We cannot see you either. We are seeing the room, but not the area of projection. Oops, you lost sharing the screen either. I can. Well, I think the first case we'll have a little bit, hopefully we'll get this.
All right.
You
really should, the way that it is set up, you should be seeing the participants in the room for the interactive presentation and then be seeing the actual case presentation. If you're not seeing the case slides,
I see the case now. So that is the thing that says
okay.
I see the case
then this isn't a problem. We wanted you to actually see the room and not the case presenter because we're going to have interaction with the room. So all right, so I'm going to actually walk a mic around for those that to help respond to Dr. Krishnan's questions.
But still at standstill. I'm on virtually still at standstill, hopefully. Okay, somebody is seeing both.
Should be seeing both.
Okay. Everybody on virtually should be seeing both.
Hopefully you just saw Braden smiling at you.
If anybody's having problems, let us know.
All right. So really quickly, we were talking about the workup, and I think Dr. George had a comment on the workup.
Seems like the weight is more affected than the height, 1%. And are we sure that the heights, I guess it's the primary doctor, were 99% for height early on?
Early
Is that
on, yes,
that
yeah.
tall?
And the weight that I have just quoted, previously was at our
20,
visit,
22nd.
22nd.
From 99 to 22nd. From 99 to 22nd, but that seems like
Mhm.
it's more of a nutritional weight issue. But yeah, workup. Although it may not be necessarily endocrine per se,
Mhm.
I think it's still, the question is, why is there such decline in growth parameters?
Yeah. Yeah. And that I think was what our provider thought and did workup. So workup, if there is anything that you all would like to. Oh, Dr. Shah is asking where we parked. So maybe you can text her that we did ballet. And so so I can start off, but if any of, there's one question, did mother stop breastfeeding? Oh, that's a good question. I don't think she was ever breastfeeding. I think she was always just formula feeding went back to work. She went back to work at, 3 months, and we are seeing this child at 15 months of age. So there's been a consistent gradual decline in weight and height since then.
Any maternal diabetes?
No maternal diabetes. Good question. Yeah. Yes, the below 2 years is WHO curves, right?
So
Even the ones that we
It was
use.
put on
Yeah.
the right curves.
Yep. Yeah. And so we thought we should do some preliminary workup, and we did a CBC with differential, which is within normal limits. But if any of you want to type in what you would like to do for workup, please type that workup in and I can look at it. Ideally, I would have asked that question to all the fellows here.
Was there any skeletal dysplasia or
Oh.
any concerns on sort of just grossly on the exam?
Nothing really. She was a very, very proportional looking kid, happy, but maybe slightly irritable on exam, but otherwise, seeing a new doctor, of course, but otherwise nothing. Yeah.
Yes, did parents complain of any activity level decrease or any issues with, like, what is it, MSK or eating habits?
No, they did not. She's always been a picky eater, but they have not noticed any major changes. And activity level, developmentally, she's meeting all her developmental milestones. So she has had steady progression in her developmental milestones. So there's no issue with that. So CBC with differential was within normal limits. ESR was okay. Celiac panel was within normal limits. IGF-1 was 16, and I gave you the normative values here. What do you all think about this? Oh, are there any developmental issues? No developmental issue. TSH and free T4, we did do that, and those were within normal limits. Any could be nutritional. Okay, yeah, definitely could be nutritional. The low IGF-1, right? Especially at 15 months of age. IGF-BP3 seemed okay. So again, IGF-1 could be low, IGF-1 could be nutritional. Now the CMP came back and that revealed alkaline phosphatase of 1162 with a calcium of 9.6. And just a UA, which is part of our workup, it was pretty okay, just maybe 1+ glucose, blood, leukocyte esterase. So this was our workup. Based on this, what would you all like to do? Further workup.
Any symptoms of DI or preference for water?
That's a good question. No, they don't report any vomiting, jaundice, diarrhea, nothing at all. Vitamin D level, yes. It was normal, 36. 36. 24 by OH, yep. Yeah, good question. 25 OH was 36 nanogram per ml. Okay, is that with an elevated alkaline phosphatase of 1162, phosphate, thank you. That would be the first, another thing that you should get. And further workup, phosphorus was 3 milligram per deciliter. What do you think of this 3 with a 15-month-old phosphorus? It is low. So I think the one teaching point is that, always interpret the phosphorus with age-based normative values, and the younger the child, they have a higher phosphorus levels. So a 3 at 15 months would definitely be considered low. Sorry?
They were asking for a bilirubin level.
Bilirubin level. I think it's part of a CMP. It was normal. But if it's not part of CMP, let's pretend it's normal. It was normal. Yeah. And so 25 hydroxy vitamin D is 31 nanogram per ml. Pretty, normal. PDH was 53, again, within normal limits. Urine calcium creatinine ratio was 0.14. And if any of you want to know the normative range for at this age, it should be anything less than 0.6.4 would be considered normal. So it's normal. And so we did do an alkaline phosphatase isoenzyme, which did show that 97% of the alkaline phosphatase came from the bone. I think that was what Dr. Lynch was referring to, what is the source of the high alkaline phosphatase? So based on that, okay, the very good question, TMP, GFR, family history. Okay, hold on. There are some good questions here. Could be nutritional phosphate, low. Girl X-ray. Okay, I'm going to get the X-ray. Family history of low phosphorus. No, there's no family history of low phosphorus. TMP, GFR, I'm going to get to that. Good question. 125 vitamin D. I have sent that off. It takes 8 weeks. So you won't get it back until it's like 3 months. So it's a good question, but you won't have it to interpret, in any time near frame. So alkaline, repeat urine analysis continues to show the specific gravity of 1.006, 1 plus glucose, 2 plus a leukocyte esterase. Magnesium is normal. And so then we did the X-ray. And this is what the X-ray shows. Any of you want to comment on the X-ray? Very classical rickets, right? So the classical radiological sign of rickets is cupping. Yep. And the other 2 signs are flaring and fraying. So irregularity of the edges, and then the widening of the end of the metaphysis, and then, of course, cupping. So classical rickets evidenced on X-ray. So further workup that you would like to do. I think somebody already mentioned TMP GFR. So we did a TRP, which was low for age. The mean was 88% for this kiddo. The tubular reabsorption of phosphorus based on calculation was 78.7%, and TMP GFR was also low for age. So based on this, what's your diagnosis and next steps? So, pardon? Yeah, hypophosphatemic rickets, right? So the child has rickets, phosphorus is low, so that is hypophosphatemic rickets. I think the kicker here is, what is the cause of the hypophosphatemic rickets? So there's no family history of rickets. And, the rest of the evaluation was okay, but the child is kind of falling off the growth curve, which is consistent with rickets. Short stature is one of the presenting symptom of rickets that we sometimes tend to ignore. But the thing here is also, there's a very subtle sign, which is, so before I go to my diagnosis, I think when you have hypophosphatemic rickets, what's your next step in evaluation? To find out why. Always ask a question, why, right? Why does this child have hypophosphatemic rickets? Pardon?
Dr. Shah was saying X-linked.
So X-linked is the most common, but you can't come to that. Can you make the diagnosis now? You don't have enough. FGF 23. So get an FGF 23 levels. That typically, if you have I was actually having a handout that I can actually send all the fellows here. So the next step would be to get an FGF 23 levels. So FGF 23 measurement has its caveats, but if you do measure an intact FGF 23 levels, what is the fork in the road if the FGF 23 is elevated or if the FGF 23 is normal? So in this case, let us pretend for XLH, what would you expect the FGF 23 to be? Yeah. Yeah, so in XLH, the FGF 20, it's the phosphaturia is mediated by FGF 23. So just because it's phosphaturic, it does not need to be always be mediated by FGF 23, but XLH is mediated by FGF 23 levels. So if you have elevated FGF 23 levels, your differentials becomes inherited disorders of phosphate wasting, which are mediated by FGF 23, which includes FEX gene mutations, FGF 23 mutations, which is the autosomal dominant rickets, or mutations in the DMPP, ENPP1. Those are all rarer causes of FGF 23 mediated genetic causes of hypophosphatemic rickets. You also have acquired causes like, McCune-Albright, skin lesions like linear sebaceous syndrome. We have a kiddo, right, that in our practice, or tumor-induced osteomalacia. Those would be the other causes of elevated FGF 23 mediated hypophosphatemic rickets. In this kiddo, FGF 23 came back normal. So then what are you looking at? Now, in her case, I did not get an FGF 23 because I had another clue in the workup that I had, and I knew FGF 23 is going to be normal. But when you have normal FGF 23 levels, what are your differential? Time to wrap up? Yeah. Okay, time to wrap up. Dr. Tregestead is reminding me. So in her case, the UA was consistently showed glucose proteinuria. So I suspected Fanconi syndrome. And we got her plugged in with nephrology. Her FGF 23 was normal, and she had cystinosis, actually. And so evaluation revealed cystinosis. She got plugged in. So it's kind of a unique case. So I thought we should discuss that. That's it.
All right. Thank you, Dr. Kirsten. All right. Yes, thank you. All right. Dr. Meyer, do you mind presenting yours next? That'd be okay. I don't see it. Oh, there it is. Yeah. Is that yours? Okay. You want to do that? Give me just a second. All right, so now joining us is Dr. Meyer from OU as well. He has another case, and I'll try and do the kind of the same thing and do a roving mic. And thank you so much for your participation online. We're so glad that we could engage you, and we'll keep this going.
All right, thank you, Dr. Tregestead. Thank you all for coming, and those of you virtually. Like Dr. Tregestead was saying, I'm Jonathan Meyer, one of the pediatric endos here at OU, and we'll move over from bone to DSD, which is my area of expertise within our section. So I titled this a case of a normal newborn, maybe, probably not. So initial presentation, we have a 39-week gestational infant born to G3P1 mom. Second child was a 15-weeker that unfortunately had a fetal demise, and there was some issues with potential postpartum depression, things like that with this mother. So this third pregnancy, of course, was a pretty big deal to this family. This patient was delivered via vaginal delivery. Initial APGARs were 6 and 8. Looking at the history, there was a history of hypothyroidism, but mom did not take any medications. It was normal during pregnancy. History of anxiety and depression, as we had already discussed, and unclear transaminitis. We're not sure exactly what was causing that. During the pregnancy, she was prescribed topiramate and pramipexole, and birth weight was normal, AGA 2945 grams. Initial exam that was done in the nursery showed a sacral dimple with the base, so no immediate concerns there, with normal female appearing genitalia and no other anomalies, and was discharged the next day. So a follow-up with PCP on day of life 3, PCP expressed concern about atypical genitalia. So kind of surprise maybe to the family, and was seen by our pediatric gynecologist at day of life 4, as family was already in clinic for a lactation visit. So they called our side and said, hey, let's take a look at this patient. I think there's something going on here that we may have missed earlier. So findings on exam at this point showed bilateral breast buds, clitoromegaly, a UG sinus with a 1 millimeter opening, just a little bit below the inferior aspect of the clitoris, and there was no visible urethral or vaginal opening. If we kind of had to do a Prader stage, we're looking at 2 to 3. Obviously, it's kind of hard to kind of show exactly what this looked like for a variety of reasons, but if I had to sort of describe it, it was just kind of a slightly mild clitoromegaly with like very, very thin caliber kind of clitoris or phallus. Gonads were not palpated during this exam. So our gynecologist spoke to me, and we plan to see the patient the next day in clinic, and I will kind of rope in Dr. George here, who saw the patient with me. So the next day, we saw this patient, confirmed this previous exam to be accurate, so something was going on. We measured the clitoris about 1.4 centimeters. Like I said, very thin in caliber, and there was clear corporal tissue. We also did confirm the bilateral breast budding as well. There was normal labia majora and normal anus. So there was no concern about anything beyond what we kind of saw with the clitoris and the UG sinus. There is no hyperpigmentation. So as Dr. Krishnan mentioned, this is going to be somewhat interactive. What additional information would you like at this point? And what are you all thinking right now?
Dr. Lynch was saying she would like an ultrasound.
So we will get to ultrasound, absolutely. Are there any labs they want to get? So I see pelvic ultrasound and karyotype. So karyotype, of course, will be very important here. And we'll get to that as well.
I'd like an LH, AMH, FSH, testosterone. Dr.
So
George wants a 17 OHV.
All of our gonadotropins, androgen levels, very good, very good. Is there anything specifically that we're concerned about in the setting where we think this looks probably like a female and we have concern for hyperandrogenism and virilization? All right. So
I was going to say, Dr. George was just saying adrenal issue with potential for excess adrenal androgens.
all right, very, very good. So yeah, so we're starting to see some stuff pop up here. Awesome. So CAH, 3 beta HSD, stat BMP. So yes, very, very good. So we want to rule out the bad stuff, right? As endocrinologists, we don't want to miss a CAH certainly here. So that was our thinking as well. And so I will get to the karyotype, but I'm going to hide that for right now. We did note that mom did receive cell-free DNA, and we had that result as well at this time, but I'll hide that for right now. We have concern for CH, absolutely. So a cortisol was 13.9. We had a sodium of 145, potassium of 5, and glucose of 57, testosterone of 7.8, and 17 OHP was 37. So what now do you think about CAH? Yeah, I'd say considerably less concerning. In the process, I didn't put this on here, we tracked out the newborn screen. The newborn screen was not consistent with CAH. We did repeat the BMP the following week. We had a sodium of 139, potassium 6.3, but it was noted to be hemolyzed and certainly not in the setting of a very low sodium level. And we had a very normal glucose of 81. And I see someone put not 21 hydroxylase deficiency, so very good.
Yes, I would argue that you haven't completely ruled out CAH, but it's not 21 hydroxylase.
That is correct. So All right, so can we rule anything? So probably 21 CH as we're discussing right now. All right, so for continued follow-up, we saw urology of day of life 17, got the ultrasound as Dr. Lynch and others have mentioned. Normal kidneys, we have a uterus, and gonads were not visualized, although they did note that there was obstruction due to bowel gas and other things, so that could have just been not seen as opposed to not present. All right, so I see some people mention AMH, consider ACTH stem test, 17 hydroxypregnenolone, DHEA. All right, anything else? Okay, so we'll go ahead and move on. We went back, looked at mom's chart in very significant depth to make sure we didn't miss anything else. Actually spoke to mom's OB as well, who received Clomid early in pregnancy as part of fertility. Wondering if that had anything to do with what we're seeing here. Our thought was probably at this point that did not have anything to do with what we're seeing after extensive review and discussion. There is no history of maternal hirsutism during pregnancy. Why would we mention that? Just think about that. No history of maternal androgens during pregnancy. And finally, we have the cell-free DNA of 46XX, which was confirmed by the karyotype. All right, so hopefully we're starting to limit things down a little bit. I'm seeing possible mixed dysgenesis and mom ovarian mass. So these are all great things to be thinking about here. So we then followed up at 1 month of age. Exam was very stable. The clitoris was certainly not more than 1.4 we measured earlier. It's probably closer to 1 at this point. Oops. Sorry about that. All right, so at this point, we're left with kind of our XX DSDs. So didn't hide these slides quite as well, but these are kind of our thoughts here. So when we think of XX DSD, where we've classically thought of this as exposure to androgens over time, that kind of have a female that develops sort of by default into this female external anatomy. We have exposure to androgens. So the most common cause is going to be CAH, and of course, within that realm, we have 21-hydroxylase deficiency, which we feel very confident is not the case. Other ones we think about would be 11-beta and 3-beta hydroxysteroid, CAH. We felt this is probably not the case here due to a reasonable cortisol level. We not have hyperpigmentation. We did not end up doing, I think some people mentioned doing ACTH or a SIM test. Felt like we had enough information to not have to do those tests, but that is something we definitely talked about and thought about doing. Some of the other causes of this potentially could be exogenous androgens, androgen secreting tumors. I think someone mentioned the maternal ovarian mass. So that's a great thought, something we, I think, very rarely see, thankfully. And then placental aromatase deficiency. In the setting of XX-DSD, we now know that there's other genes and transcription factors that can lead to this virilization and sex reversal. So this is kind of developing over the last, probably 10 to 15 years. And so if we kind of had to summarize this in a chart, this is kind of the classic way we thought about XX-DSD. We had a sort of default female fetus that got some sort of androgens for the reasons we discussed, and then looked more male or virilized at birth. Within the CAH picture, we're thinking of 21, 3-beta, or 11, potentially, the first 3 steps here, which is going to shunt everything over to androgens. And then other causes, of course, as we discuss are the factors, we think of changes in WNT4, DAX1, RSP01, NR5A1, and others that can lead to sex reversal as well. So there are some things still on the table here. And so at this point, we decided what are we going to actually do with this patient. So in the setting of DSD, When we talked about the whole spectrum, we did not have any documentation of any sort of reason to think she had a maternal mass, exposure to androgens. And so even despite the lack of maternal hirsutism, at this point, we think our best bet here is probably actually placental aromatase deficiency. But to test that, we're deciding if we should do a single gene or multi-gene panel. And so this would be one of the first opportunities we've had to talk about an XX DSD panel. And so those of you who came to festival last year know I talked about XY DSD. This will be the flip side of that, which is not nearly as probably developed in literature as XY. So we can do things like exome slice, whole exome sequencing, and whole genome sequencing. And so we usually would start with the exome slice. And a proposed panel here would be something that may include 11B1 and HSD3B2 to look for forms of CAH. Look at other factors as we talked about, NR5A1, among others, and of course our aromatase deficiency, CYP19A1. And so this is in process right now. So we actually don't know the 100% answer, but hopefully we'll get that soon. And just want to comment this really quickly as the last slide. Since we don't talk about this very much, if this actually happens to be the diagnosis, we're concerned about lack of conversion from androgens to estrogens. So this female infant would likely be virilized, especially over time. We usually see virilization in both mom and fetus. So the fact we didn't see it so much in mom is not a clinch to this diagnosis, but something we certainly have to consider. And testing is definitely worthwhile if we think this could be the case, because we're definitely at risk for virilization. You treat this with estrogen as early as 2 years of age. And as I mentioned, we're still going to find out the diagnosis. So pearls in this case would be about placental aromatase deficiency, XX-DSD panel, which is developing the literature. And then from the very beginning, just never take a newborn exam for granted. Thank you very much. Any other questions?
Was there anything unusual about their ethnic racial background for this family?
This is a Caucasian family. There's nothing within the family history that would be concerning in terms of ethnicity or anything.
We've had a couple babies born with clitoromegaly XX that's transient but lasts for a little while, with mothers that say in their area of, I think one was Congo and one was so similar in Africa, this is a common in their village problem or issue with the girls, and they ignore it and it goes away. And they were right. They chose to ignore it and it went away. But I wonder if it's like a transient version of that as well.
Yeah, it's very interesting. And, it looks like the clitoromegaly may be resolving. And again, I don't know the full anatomy of the patients you're discussing. If it's just a clitoromegaly, actually, I feel like they may be resolving, but of course we still have what it looks like a UG sinus. And so that will of course be further worked up as well as this patient gets a little bit older. Urology is going to take a look, but yeah, we'll have to kind of see if anything comes of those cases as well. You can kind of fill me in.
And I also had a patient last year whose mom took testosterone pellets during pregnancy because her libido dropped.
Yep. So there you go. There's a maternal androgen exposure.
Fun.
And we all know that history taking, we do the best we can, but that's not a perfect science. So.
All right.
All right. Thank you very much.
Thank you, Dr. Meyer. We appreciate it. All right. Okay. Let's see here. Yeah, let's go ahead and we'll let Dr. George take over here. There is, if he shows up. No, it's actually
Dr. Sebastian is here.
It's Dr. Steelman's case. So we'll see. All right. So next, we have another case from Dr. George, also from University of Oklahoma here with us. And we'll let him talk. Thank you so much for engaging both in the room and virtually. Gotcha, Dr. Steelman. Okay. We will go ahead and let Manu present this case. And as soon as he gets that, we may see if we still have a few moments. Dr. Steelman thinks he can present remotely, so we may have a little bit of time to squeeze in his case as well. It's live from I-35. He's telling me he will present his case, and then we can kind of following this will be kind of the career discussion, and that's going to be a little bit more informal as well. So we may have time to do that. All right, please welcome Dr. George. We thank you very much again for your participation.
Well, thank you. Thanks, Jeannie. My name is Manu George. I'm one of the pediatric endocrinologists here. And thank you all for being present virtually or in person here in Oklahoma. So this is a patient that we've seen over the last 15 years, and I've gone back a little bit. So 2 years and 11 months of age is when we first saw this child. And the chief complaint at that visit was obesity from early infancy. So if you look back, this child was born at 8 pounds, 2 ounces at 38-week gestation. So not just normal AGA. And there was no complications in the pregnancy. The history was only significant for some polydactyly that was removed early in infancy. General surgery removed the extra digit. And the height at 2 years, almost 3 years of age, was at the 72nd percentile, and the weight was at 100 percentile. And the family felt, compared to the other members of the family, she looks different, and also feels like she's gaining weight at a much rapid pace compared to her older brother and the family members. Any thoughts so far? Just with the polydactyly? Maybe. All right, we got a little bit more. So they were seen. Michelle Zera. Okay. She's got a suggestion there. So we'll see if that pans out. So height was 103 or 84th percentile, and weight again 100 percentile. A year later, when the child was seen, then they got lost to follow up for many years, and so I guess one of the teaching points or learning points here is that if you have obesity before 5 years of age and it's pretty aggressive, greater than 3 standard deviations, you definitely want to not just chalk it up to exogenous obesity or dietary. You definitely want to look for other things and see, based upon the other things, if you need to do a genetic panel or look for an underlying etiology. We see so many obesity in the population. And so I wouldn't necessarily go through this, but based upon some other signs and symptoms, you could certainly look for certain types of obesity syndromes. And then there's certainly algorithms out there for early onset obesity, severe obesity, that you could kind of go through a differential based upon, your leptin levels, or is there height and weight that's stunted, and various other things like malformations to come up with a diagnosis. So this child came back, and this is the first time I got involved. So this is a 7-year, 4-month-old at this time, and the family was kind of lost to follow up for 4 years. And they came back, primary doctor sent him back saying, you got to go get it looked at. 85% for height percentile still, and the weight is gone up further, and it's still at the 100th percentile. The BMI was, I want to say that's a typo, 30.53. And so it was definitely very elevated. And the TSH this time when I did it had a TSH of 7. Certainly not enough to explain any of this obesity, but I did a TPO and a TG, and that was positive, and the child was started on levothyroxine. So certainly, true and unrelated probably, that the child developed autoimmune thyroid disease and was on the appropriate treatment for that. But the TSH of 7 doesn't, and a free T4 of like 1.1 doesn't explain the amount of weight gain that this child has. Did not have diabetes, but certainly at this age of 7 had hyperinsulinism, acanthosis, and was starting to have elevated liver functions. And they emphasized to me how this child doesn't necessarily eat a lot and is active just like the rest of the family and is gaining weight at a rapid pace. So with the extra digit history too, kind of had a hunch of what's going on, just like someone said here. Yeah, some developmental delay. So I think I see some questions here. Is there hyperphagia? Not so much hyperphagia. And developmental delays, yes, some mild developmental delays, not severe developmental delays. So what do you guys think on in here? Or I think a couple of people have gotten it. Vision, yes. Wears glasses at that first visit, but good point about the vision. Why? Yeah, retinal pigmentosa is part of one of those conditions, right? So if you have retinal pigmentosa and obesity, you would think about what condition? Bardet beetle, and I think a few of you on the chat has come up with the right diagnosis. Now, the point wasn't just to bring up Bardet beetle, but also to bring up that, you know, if you have obesity early onset, you definitely want to maybe look at other things. But the story doesn't end here. So Bardet beetle is an autosomal recessive disorder involving the kidney and the eye, and it's a ciliopathy, right? And there's more than 21 genes, I think, at this point. And the most common is BBS1 and BBS10. So 51% BBS1, 20% or so BBS10 gene mutation. And there's not any specific or targeted treatment at this time. So it's more, you know, either dietary issues, bariatric surgery, and weight loss strategies rather than any particular medicine, including the latest medicine that's Imcivree, right? This is not one of the approved indications. So we were following this child for in the clinic, you know, sporadically. She was also followed by nephrology for hypertension, followed by hepatology for the fatty liver. So she was 13, 14 and still hadn't had her period yet. She had some mild signs of hyperandrogenism, PCOS type of picture. So, and the mother who is Asian said that she didn't have her period until 15. So we kind of waited a little bit longer than I normally would. At that point, since there was no period by 15, we sent her to Peds GYN for primary amenorrhea after looking at some labs. And over that period that we were following her, it turned out that her hyperandrogenism got worse and her testosterone levels were very significantly elevated. When I mean significantly elevated, I've never seen testosterone levels this high in a boy or a girl. But let's look at that. So recently the child underwent an interventional radiology procedure to isolate where the testosterone was coming from. 4,780 from the right ovary, and the left, as well as all of the other adrenals and systemic, was 500s. So clearly for 46XX female, the testosterone level is you know, like a man overall in the system. So that's why we went searching, and the right ovarian vein showed 10-fold increase from there, 4,760. So any thoughts, fellows? Dr. Sebastian? Maybe Bardet beetle has urology issues too, I think. Okay. Any other thoughts? I actually had to, because the testosterone level was so high, I had to talk to, I think, Dr. Aukus and the adrenal experts around the country to see, you know, and so he pulled up a 1980 article that said that there is this association between Bardet beetle and this particular condition called ovarian stromal hyperplasia and hyperthicosis. So The cases that are out there are usually older, after they've had their first period of they've had their menarche. They usually develop virilism, virilizes, and then they'll have, secondary amenorrhea. And in some of these cases, there's sky high plasma testosterone noted, and peripheral vein sampling has been done, and histological evaluation of the ovaries has demonstrated stromal hyperplasia with focal hypertrichosis. And so the adult patients had it in both their ovaries, and bilateral ovarectomies have been reported from those cases. And so this particular patient last week underwent a one-sided, right-sided ovarian removal for treatment, and the ovary, the results just came back as earlier today. The ovary shows fibrosis, hyperplasia of luteinized follicular thecal cells and luteinized stromal cells consistent with ovarian hypertrichosis. And so the gold standard for diagnosing this is histopathology, or getting a sample after removal. And they normally see these presence of nests of luteinized cells in the ovarian stroma. So I have a picture of this, and I'm not sure if you guys can see that the usual spindle shape of the cells in the surrounding areas, and then these areas of stromal nests of luteinized theca cells. And so this is from up to date, this picture, not our patient. We haven't had our pictures come through yet. And the pathologist said the pictures won't be ready till next week. So some learning points about Bardet beetle being, or other endocrine causes of weight gain being looked at for obesity that is unexplained of young age, and that is pretty severe. Along with Bardet beetle is just one example, but there's so many others, right? And then there is this, I think the first ever primary amenorrhea may be caused by this hypertrichosis seen in a BBS.
All right.
Questions?
Any questions for Dr. George? Dr. Meyer, hang on.
Maybe Bardet beetle. Oh, let's see.
So what strings do you have to pull to get the ovarian vein sampling done?
Yeah, so there's one board certified pediatric GYN in the whole state of Oklahoma, pediatric GYN, and she was integral in helping with getting that sample in the OR with interventional radiology. So I don't know if it was her or interventional radiology, but she was the one that did the surgery. And the case reports say that's the best way to, localize it. If we had to remove both ovaries in this young child, I mean, obviously it had to go through ethical consults.
Let's go to the ethics board. No, we can be.
Yeah.
All right. Well, thank you all so much.
Joel?
We have guests coming for our next section, but we may hang on with you guys for just a second, because I'm going to see, since we got started just a little bit late, we still do have Dr. Steelman's presentation. Dr. Steelman, you still, okay, what did you do with my chat?
Oh,
Yes, and then it goes away and I don't know how to get it back. I have to have Brady come back. It's okay. Don't minimize my chat, man. It's at the top over on that screen. No, it's not the same screen. So I have to figure out how to get over to that screen to get it back. So it's one of those things. Hang on just a second. I will be able to see the chat here shortly. Hopefully. Yeah, I don't know how to get over. Oh, here he goes. Okay. Is that the chat button? Somebody help me. Okay. Here we are. We got it. Okay. All right.
Can I make a correction?
Sure.
So Imcivree is approved for Bardet-Biedl here lately.
That's kind of what we were
Yeah,
thinking.
yeah, that's right.
Okay.
My bad.
Okay. Dr. Steelman, we can try and do yours. I can run your slides. I'm not sure if you can unmute. If not, I can call you and I can have you, we can have you on my cell phone. Exactly. That's exactly what I was about to say. Let me call you. Okay, I can hear you. Let's see if everybody else can hear you if you talk.
Can you all hear me?
Perfect.
Okay. I don't think I've ever done this before, but this is just crazy. So anyway, I will do my best to see if I can see the screen. But if you want to go ahead, I was solicited for doing cases. So this was actually a patient whom I followed for several years that I had seen recently, and I thought this would be an interesting case. And certainly we've had our share of endocrine cases, so this is a nice sort of finisher with diabetes. So next slide, please. So this is a young man that I started seeing in 2019. He had previously been followed by the nephrology service. And oh, by the way, if anyone has problems hearing me, please, just feel free to interrupt me, okay?
I think we're good.
Okay, so he was 13 at the time. He had been followed by the nephrology service for about 4 years previous with chronic kidney disease. So he was incidentally detected after an episode of strep pharyngitis to have renal failure. And the initial thought was that he probably had like post-streptococcal glomerulonephritis, but his workup was notable for multi-cystic kidney disease, and there was no signs of post-strep GN. So the working diagnosis on him was chronic kidney disease due to autosomal recessive polycystic kidney disease. He was in for just a routine check, and they found a glucose level of 311 on him. And you can see on the right side of the screen some of his other studies. So let's go to the next slide, then we'll pause here for a second. So, in seeing him for consultation, he had, some history of polys. He had not lost any weight. He had not really had any other constitutional symptoms. His past medical history, they had noticed cysts in both kidneys on prenatal ultrasound. And then, as I mentioned, he had, what appeared to be initially acute renal failure, but then progressed to persistent chronic kidney failure that worsened. He was stage 4 kidney disease when I saw him. Nephrology had worked him up and had found negative genetics for autosomal recessive polycystic kidney disease. He was doing well overall. He was growing and gaining weight in spite of, his chronic kidney disease. He did have renal osteodystrophy, and they had just treated him with calcitriol and no phosphate binders. His family history was notable for being negative, pretty much. There was no strong history of diabetes in the family. There was no history of autoimmunity. That includes type 1 diabetes, other rheumatologic conditions, celiac disease, and no history of polycystic kidney disease. Next slide. Okay, and then on his initial, assessment with me, these, were his vital signs and pertinent findings. Pretty much a very unremarkable exam. He was a bit overweight, obese, and I repeated his lab studies. This was a fasting lab specimen, and I went ahead and did a fructosamine on him as well as doing an A1C. So let me stop and ask people what their thoughts are now. Or any other questions on the history before we kind of proceed on next steps.
Okay, Manu, you're gonna have to run with the mic. Anything in, I was gonna say, I'm watching the chat too. Anything in the chat?
Let's see here.
No family history of diabetes, right, is what he said? No family history of diabetes. Was there a CBC? I mean, I guess the A1C could be off if you have kidney disease. But the glucose was elevated.
That's correct. So the patient had, both a random of 311 in the clinic, and then I got a fasting specimen on him, which again showed diabetes based on ADA criteria and an elevated hemoglobin A1C. So he appears, by all accounts to have diabetes mellitus at this point.
Rule out type 1, type 2, MODY. No family history.
Correct. No
Is
family
a type of
history.
MODY with the kidney?
Really, as I recall, I think maybe like an older relatives, kind of like you'd hear most of the time, older relatives with type 2, but no like history of people diagnosed at a young age with insulin requiring diabetes.
There's a
So,
particular MODY
early onset.
with renal cysts, right?
And again, overweight, but no, and also Caucasian too. I think I had mentioned in the history. So not very, ethnically white with no, not biracial. Next slide. So after I got the confirmation of diabetes, I brought the family back and went forward. And, from that standpoint, we still had diabetes mellitus and needed to have some type of intervention planned at this point. So the family was brought back. They were given education on home blood glucose monitoring and education on ketone monitoring. They were taught insulin administration as well, and additional lab investigation was ordered. And you can see the testing on the right. And as Dr. Krigstad said, one of the first thoughts was, could this be type 1 diabetes mellitus? So you can see the antibody tests on him for the autoimmune markers were negative. So next, before we go on to next slide, does anyone have any additional comments at this point? Anything else that you would want to pursue, or based on having a hemoglobin A1C of 8.1%, anything that you would want to consider therapy-wise in this young man? Beyond teaching them rescue insulin and having basal insulin on deck in case it's needed.
You have some audience members that still want some genetic testing.
Okay. What would you like to test genetically?
Oh, sorry, MODY, I don't remember which one, but there's one with renal cyst and diabetes, especially polycystic kidney
I'm
disease.
sorry, I couldn't quite hear you, but you were saying MODY testing,
sorry.
and there's one,
I'm sorry.
and then I think I couldn't quite hear what you were saying.
Oh, sorry. What I was saying, I don't remember which MODY, but there is a MODY that's associated with renal cyst and diabetes.
Okay.
So
All right.
there's no family history. It seems very
Okay.
suspicious.
I think that's a very good idea. Next slide, please. So we basically, and then the question is, and we'll ask the audience here in a second. So they were taught monitoring because he was overweight. The family said, can we do lifestyle changes and not start insulin? So I said, okay, sure, we can do that because he was not overly symptomatic. So we have diabetes, and again, the family called with home readings, and there was nothing extremely concerning. So, what do people think at this point? You know, these were sort of my thoughts at the on the right side as far as differential. So, what do people think of 1, 2, or 3? What is the strongest candidate at this point?
Actually, from chat, you have someone asking if there was a lipid panel or what the triglycerides were, which might help us with the differential.
That's an excellent question. The lipids on him were mildly abnormal, so kind of the obesity pattern. The HDL was a bit low. The triglycerides were a bit high, but he wasn't insanely high. Like a metabolic syndrome kid or someone with something else going on. I mean, chronic kidney disease certainly can push up too.
Okay, we'll do it this way. Who votes 1? You have no takers on number 1.
I don't see. All right. And do you have any takers on number 2? Do you have any takers on number 3?
You got a whole bunch of takers on number 3, both in person and online.
These people are smart. Okay, let's go on to the next one. Okay, so again, the question is, what do we do treatment option wise on him as well too? And I think people have already said, let's do genetic testing. So, okay, we'll order that. So what do people think should be the treatment option? Should we just observe this young man? Should we start metformin, maybe a GLP-1 agonist? Should we just start basal insulin or go cowboy and try like Farxiga or some other, type 2 adult therapy? What do most people think on that one?
You've got an online vote for some Basalantis.
Okay. Always a good idea. Does anyone, next slide, I guess I broke down my thought process.
I was going to say, I'll interject really quickly that some of those that you mentioned with him being at CKD4, I would not use.
Correct. Yeah. So that was the point. So next slide, please.
Okay, there you go.
So again, the CKD would be concerning for lactic acidosis risk, which is why I was a little bit reluctant to use metformin. The GLP-1 agonists maybe is a possibility. His age, though, would probably make it unlikely that there would be approval that you would get. And of course, there's other issues. Basal insulin would certainly be good too, but you do have some hypoglycemia risk. And of course, you can do lifestyle. The problem with staying pat, though, is that, certainly if this is type 1, he's going to progress and, develop insulin deficiency. If this is type 2, lifestyle changes don't generally, fix type 2 in most cases. Next. And then, okay, so, but we still have no working diagnosis. So again, this is just ADA classifications, just talking about the different types of diabetes. And again, he doesn't really fit conveniently into type 1 or type 2. So again, we're still working on a diagnosis while following this young man. Next slide. So what about monogenic diabetes? Everyone seems to think that's a possibility here. The thing that's missing in this young man's case, though, is there's no multi-generational family history. But, if you look at other criteria by the ADA, he would certainly be someone that would be worthwhile scrutinizing. Next slide. So this is just an illustration. So I don't have the benefit of teaching house staff or fellows at this point. So I have medical students. And one of the things I try to talk to them about is that we have so many tools. So it's really just a matter of, and even if you're not the brightest or sharpest person in the world, Google and other searches can really help you out as long as you have a, inquisitive mind. So as someone had mentioned, I thought, this doesn't seem right. Let me just do and again, as you get more years under your belt too, there's a lot of knowledge and some of it kind of gets shoved away into the back corners. So, again, I was suspecting probably Modi and my Google search again kind of pushed me in that direction. Next slide. So there are the different types of MODI, and there's the reaction I got from the insurance company when I put in for MODI testing, which I actually requested fairly early on in his course. But again, he would fit, with renal abnormalities, he would fit in the MODI 5 category. Next slide. And so I requested MODI testing in fall of 2019. So about 4 months after I saw him. He had follow-up at the beginning of 2020, and his A1C had crept up. The family had really not wanted to start any kind of therapy, and so we were watching carefully, and nephrology was watching carefully. But there was a gap in follow-up. Can anyone tell me what the culprit for that gap was in 2020?
You got the whole room echoing COVID.
Our lovely friend COVID. So this family was off in isolation, and he came bopping in with hyperglycemia and some ketosis and an A1C at that time of 14%. So he basically was started on basal bolus insulin. It was decided not to repeat his type 1 diabetes antibodies, but that the escalation and being a little bit more stringent finally got insurance off the mark with testing. Next slide. And one eternity later, we did have positive results. This was like, I think, 2021 or something by the time I finally got his results. So we do now have a diagnosis. So the question is, what is the treatment that we might consider in this case? So we have at least a proven treatment that was successful, at least early on, with basal bolus insulin. Does anyone have any thoughts on, whether we should persist in that treatment, or is there any other therapies that we might consider?
Sulfonylurea is a thought that someone had in the room.
Very good, because a lot of MODIs, if you diagnose them, can be treated with sulfonylurea. It's the same thing too with several of the neonatal forms of diabetes mellitus. So it's very important, because insulin is not without risk, and it requires definitely a lot of work, for adherence to treatment. And certainly in his case, because of his chronic kidney disease, which was also progressing and worsening during this time, there was a consideration for looking at other things. But again, with all things, it's important to go back and look and see what's published. Next slide. So, and I think, I can't quite read this here. The other thing too that's important is, when you know what the condition is, doing some additional research to see what else might be associated with the condition. And in this particular case, there is, pancreatic hypoplasia, exocrine pancreatic insufficiency. And with investigation, he was checked. He had a normal pancreatic ultrasound, but he had a low fecal elastase. Next slide. And so he was referred to GI, who then started him on enzymatic replacement with Creon. He also, incidentally, with GI, and during his pancreatic ultrasound, they saw evidence of fatty liver disease too, which has been associated with this condition. May also be associated too with obesity, which probably was one of the many triggers during the pandemic that finally pushed him over the cliff and caused him to decompensate. He worsened and had a cadaveric renal transplant, and was on steroids for a while after that, but has done fairly well. Unfortunately, his graft has not been behaving itself, so they've had a lot of visits to the hospital and investigations. And with all that, and just being a teenager now, his A1C at his recent visit was 10.4%. Next slide. I think I might have said. The other thing that I neglected to mention. So I kept him on insulin for two reasons. First, because of just the more unstable nature for CKD, and also looking again at what's been published. The MODY-5 doesn't generally respond to sulfonylureas. So that was the rationale for continuing him on intensive insulin treatment. So again, the point of this case is that, you know, when things don't add up, it's important to take off the blinders and look a little bit more carefully and make sure that you know the type of diabetes you're dealing with, both from the standpoint of having the right targeted therapy and also searching for other comorbidities that might be associated with that particular diabetes, like renal failure or exocrine pancreatic dysfunction. And of course, genetic counseling too, since this young man has a 50% chance of passing this on to offspring.
When they did the kidney transplant, was there any thought of doing a pancreas transplant as well?
Interesting thought. No, I don't. I mean, Cook does not do pancreatic transplants. I don't. And again, maybe if there's someone who has more expertise in that to weigh in, but I would think that, to my knowledge, most pancreatic transplants are done in older people who have chronic, complications and renal diabetes. So I don't think it's done in younger, healthier people, even though he's not maybe baseline the most healthy compared to his peers.
I'm going to interject real quick because we have a couple with different syndrome. For example, Alport syndrome, where they actually do both. So even a younger person.
Quick question.
Okay.
Was this
That's
like,
an interesting question. I'll look into that, although he's been transplanted, but just as a retrospect to see if maybe that might have been a consideration.
was this where the parents genotype, was this like a de novo mutation, or is there like
It
variable
appears to be a
parents?
de novo mutation.
Okay.
Since neither parent had symptoms, neither had, renal problems. I didn't, because of all the pain of having to getting insurance approval for genetic testing, I did not have the opportunity to test the parents.
No, I was just, was there like variable expression of this mutation that was like, like even if the parents don't have the symptoms, will they develop it later? I was just curious.
MODY-5, usually the parents should have had cysts by now. The cysts are really early in MODY-5. I actually have a patient with MODY-5 as well. So the cysts are really early. All right. Well, thank you, Dr. Steelman. Thank you for presenting from I-35.